Hi, I'm John Pellerito. I'm from the North Shore LIJ Health System and the Hofstra North Shore LIJ School of Medicine. My topic today is venous duplex examinations. What else can you see? And I'm going to talk about some of the non-venous pathologies that you can encounter during your lower extremity venous examinations. In this presentation, we're going to discuss the numerous findings that can be encountered during the venous examination. These findings can indicate the cause of pain or swelling that exists apart from venous disease. And of course, recognition is important to institute appropriate treatment. Some of the non-vascular pathologies that we will discuss include edema, hematoma, lymph nodes, and popliteal cyst. These are the most common abnormalities that we see during our studies. Less common pathologies include abscess, joint effusion, adenopathy, and tumor. Let's start out by talking about the most common abnormality, soft tissue edema. This obviously is a common cause of limb swelling. It is associated with elevated venous pressures. Causes of increased hydrostatic pressure includes congestive heart failure, fluid overload, as well as deep vein thrombosis, venous compression, and venous obstruction. On this grayscale image, you can see fluid interspersed between the soft tissues of the lower extremity. Besides seeing fluid in the tissues, congestive heart failure is associated with increased pulsatility in the venous waveforms. As you can see from this image, these waveforms are usually bidirectional. And this finding is also seen with tricuspid regurgitation. This occurs because there is increased transmission of cardiac phasic changes. And if you look at the waveform, you can see that it mimics arterial pulsations. So you have to be certain where the sample volume is before making your interpretation of the flow pattern. Here's a look at a chest x-ray in a patient with this flow pattern. And of course, seeing the increased pulsatility makes one think about the possibility of CHF or tricuspid regurgitation, and you can see on the radiograph the patient is in congestive heart failure. Venous congestion is associated with bilateral leg swelling. And a study that we did a few years ago showed that DVT in bilateral leg swelling with no risk factors is less than 5% of cases. But it's important to recognize that in patients with risk factors, this can increase in up to 23% of patients. So in the absence of risk factors, bilateral leg swelling is usually not associated with DVT. But with risk factors, you have to consider the possibility of underlying clot. When we see patients with soft tissue edema, we typically will see that fluid collects in the subcutaneous tissues. And in this image, you can recognize a marbled or reticulated appearance. We see the anechoic fluid interspersed between the soft tissue. Sometimes you'll actually recognize collections of fluid in patients that have marked edema. With soft tissue swelling can come attenuation of sound. So if you have marked attenuation, you may want to consider switching from that high frequency linear rate transducer to a lower frequency probe. Lymphedema is also associated with leg swelling, and this can also be unilateral or bilateral. Lymphatic obstruction, which produces the fluid that we see in the tissues, is associated with malignancy, trauma, and prior surgery. And the appearance is very similar to what you'd see with soft tissue edema. One difference may be that you may have concomitant lymph node enlargement. Hematoma is another soft tissue abnormality that we may encounter during our lower extremity duplex examinations. Hematoma may be a focal abnormality, or it may present as diffuse swelling in patients that have underlying pain. One thing is important is to elicit a history of trauma, prior vigorous exercise, surgery, or anticoagulation. These are important factors when considering the etiology of masses in the soft tissues. The mass may be cystic, complex, or solid in nature, and may have smooth or irregular borders. One feature of hematoma is that it will retract over time, and so following up these abnormalities may be helpful when the etiology is uncertain. Hematoma may spread within the fascial or muscle planes, and it may become hypoechoic or isoechoic to tissue. One of the key features of hematoma is that there will be no flow in the mass or collection on Doppler study. We want to assess in large hematomas whether there is actual compression of underlying venous structures, because this is certainly going to produce abnormalities related to venous obstruction, as well as the potential for underlying DVT. And when there is compression of the venous structures, you may have low velocity flow, which may be difficult to detect. So whenever we see low velocity flow, particularly with loss of phasicity and waveforms that do not have any pulsatility, we may want to consider proximal obstruction. Muscle injury is another abnormality that can be associated with lower extremity pain and swelling. This may result from blunt or penetrating trauma. It can also occur with a muscle pull or tear with exercise. It is associated with hematoma and inflammation. In this particular example, you can notice that there's a hypoechoic structure within the body of the muscle, in this case representing bleeding within a muscle tear. Initially, the hematoma and injury may be hyperechoic and heterogeneous, and over the course of time may become more intermediate to low echogenicity. Lymph nodes are another common abnormality that we see during our duplex studies. Lymph nodes can occur in the groin, cervical regions, and axillary regions during our studies. We also see lymph nodes in the perivascular areas, such as around the aorta, inferior vena cava, and iliac vessels. It is important to recognize the normal lymph node. We typically describe a normal lymph node as having an almond shape with a hypoechoic peripheral mantle. Here you could see on the longitudinal view of the lymph node, we have a hypoechoic periphery, and then we'll see an echogenic hilum, usually containing fat and blood vessels. The normal lymph node is usually less than 1 centimeter in diameter. So in the example in the top left-hand side here, you see the longitudinal view, and then on the axial view you can appreciate the peripheral hypoechogenicity and the central echogenicity related to the hilum. Lymphadenopathy is identified as a large area of enlarged lymph nodes or masses. They may cause swelling due to venous or lymphatic obstruction, and when inflamed, can cause underlying leg or extremity pain. Here we have a very enlarged lymph node with normal architecture where we can see peripheral hypoechoic mantle and a central echogenic hilum where the vessels will pass. Color Doppler will typically reveal arterial flow in the hilum, which we can identify right here. We see the central feeding vessel with branching from the center of the lymph node to the periphery. If we sample these vessels with pulse Doppler, we typically will see a low resistance arterial pattern. Now, this pattern doesn't necessarily distinguish between inflamed or malignant lymph nodes, so it's not a discriminating feature. In fact, distinguishing inflammatory from malignant lymph nodes can be difficult. Benign or inflamed lymph nodes typically maintain their normal ovoid shape. In other words, the short axis diameter is less than half of the length of the node. And besides maintaining its normal shape, typically we will see that the central hilum is intact, as we have in this example. Malignant lymph nodes, on the other hand, tend to be rounder. They lose the echogenic central hilum. As we see from this example, notice here we just see a heterogeneous mass without the normal architecture of the lymph node. And with color Doppler, we can see irregular branching and disordered vascularity. And these features tend to be helpful in distinguishing malignant nodes from inflammatory nodes. Another common finding is a popliteal cyst. A popliteal cyst represents a focal fluid collection found behind the knee, posterior and medial to the knee joint. Fluid typically collects in the gastrocnemius semimembranosus bursa due to inflammation. This can be related to arthritis, such as rheumatoid arthritis or degenerative joint disease, may be related to trauma, infection, dialysis, or hemophilia. And although the typical popliteal cyst is a localized collection of fluid, it can extend into the calf muscles and may rupture. This will produce underlying extremity pain, tenderness, and clinically can mimic deep vein thrombosis. Typically, the popliteal cyst is termed the Baker's cyst, and this occurs when it's seen adjacent to the medial head of the gastrocnemius. In this location, popliteal cyst or Baker's cyst are synonymous terms. And as I mentioned, they're commonly found during our venous duplex studies. The classic popliteal cyst will appear as a simple cyst with smooth margins, with well-defined walls, no internal echoes, and good posterior sound enhancement. Here in this example of a popliteal cyst, you can actually see the connection with the underlying bursa. Now, popliteal cyst can become complicated, usually with rupture of the cyst. And when the popliteal cyst becomes a complex cyst, it may demonstrate irregular cyst margins, echogenic internal debris. You may see extension into the calf, but there should be no internal vascularity. And this is one way we can distinguish it from some type of mass or tumor. The differential diagnosis for a complex Baker's cyst would be hematoma, abscess, and edema. As I said, we can exclude tumor by the absence of vascularity. Less commonly, we may identify a joint effusion during our investigations for lower extremity DVT. In this example here, you can see there's a collection of fluid in the joint space, separating the joint capsule from the underlying bone. And the fluid here is anechoic. Many times we'll see distension of the joint capsule with fluid. This can be due to an inflammatory, infectious, or traumatic event. And of course, if we're concerned about infection, we can use ultrasound to guide needle placement to sample the fluid. These effusions may appear simple or complex on our ultrasound studies. Many times we'll have patients who present with pain, swelling, focal skin thickening, and erythema. And in those patients, we consider underlying infection. Now, they may be difficult to identify, but there are certain things that we can look for to help with the diagnosis. As in this example, you can see that there are collections of fluid interspersed in the soft tissues, and there will be overlying soft tissue swelling, erythema, local pain that help us to look for a diagnosis of soft tissue infection or cellulitis. Cellulitis representing a diffuse soft tissue inflammation of the skin and subcutaneous tissues. And of course, anytime we have a focal area of pain or swelling, we need to be careful to exclude underlying DVT. Now, sometimes when we evaluate patients with infection, we may actually identify an abscess. And we can make the diagnosis by finding a well-defined collection in the soft tissues, as we have in this particular case. The collection may be simple or complex in appearance and may contain gas bubbles. And we recognize the gas bubbles as very bright reflectors, which may produce comet tail or ring down artifacts with posterior shadowing. Commonly, there'll be peripheral vascularity around the wall of the abscess, and also a typical finding would include increased echogenicity of the fat surrounding the abscess. And notice here how bright the surrounding subcutaneous fat is around this focal fluid collection, which was evidence of an abscess. One thing we must consider when we find soft tissue masses during our venous studies is the possibility of underlying tumor. Less commonly, they can cause leg swelling and tenderness, and may be benign or malignant. Solid masses in the tissues need to be distinguished from superficial or deep vein thrombosis, and this can be difficult, particularly in the calf where the veins may be difficult to find, and we may see small, scattered hypoechoic lesions that can represent tumors. A particular example is neurofibromatosis, where you'll have multiple masses associated with the vascular structures of the calf. Benign tumors are not uncommon. They may represent lipomas, hemangiomas, fibromas, desmoid tumors, as I mentioned, neurofibromas, and of course leiomyomas. Lipomas are the most common benign soft tissue tumor that we will see. They tend to be iso or hyperechoic to the surrounding structures and can demonstrate scant internal vascularity. They may require CT or MR for definitive diagnosis. Malignant tumors may be related to primary or metastatic disease. The more common primary neoplasms that we may see would include sarcoma and lymphoma. Metastatic disease, one should think about lymphoma, leukemia, or melanoma. These are typically solid but may be complex. And if we turn on color Doppler, we can see internal vascularity. And the classic flow pattern for malignant masses would be a high velocity, typically greater than 25 centimeters per second waveform with a low resistance arterial pattern. So be sure to sample the vessels that you see in the soft tissue tumors when you encounter them during your exam. One last example that I wanted to share would be a non-venous vascular pathology. And in this particular case, this patient presented with right leg pain. And we notice here that we're looking at the femoral vein and the superficial femoral artery at the mid-thigh level. And in this particular case, we notice that the superficial femoral artery is patent to the level of the mid-thigh, and then there's abrupt cutoff of flow. And the arrow is pointing to a collateral vessel. So in this particular case, right leg pain may be related to arterial occlusive disease. And since the artery and the vein always run together during examination of the deep structures, one should always be paying attention to the arteries as well as the veins, looking for evidence of arterial stenosis or underlying arterial occlusion. This patient went on to have a magnetic resonance angiogram to better delineate the extent of the arterial occlusive disease. And you can see the nice correlation between the duplex examination showing occlusion of the superficial femoral artery at the mid-thigh level, and the MR also demonstrating the arterial occlusion and the collateral coming off at the same level. So in conclusion, there are numerous non-vascular findings that are common during the venous duplex examination. The cause of the extremity pain and or swelling can be identified by being careful during these examinations to pick up these non-vascular findings. And recognition of the finding is critical for appropriate diagnosis. And of course, integration of the clinical history with the sonographic and clinical findings is essential to accurate diagnosis. Thank you.